really, my wife future daughter-in-law, she went and got some stuff, and I did some things, and then one of my friends, anyway, it turned out. How are you? But it was just cool because I really didn't care. I really didn't have it together. I think I'm kind of gotten whatever. We're really into MRA, and yeah, and I'm the same way. Yeah. That's right. Except for my mom, I always buy my. Sorry. Feel better. Thank you. I'm going to change. One of the streets are far away. I don't pay for parking. What? I don't mind walking. Oh, that building. Oh, there's a big one. What are you doing? No, go ahead. Sit down. Go. Oh, good. Yeah, everything going okay? Going smoothly and well? The only good about it is, yeah, you don't have yeah, do that. Work. It just needs that now. The other does not. It's very hard. That's what I'm doing with it. That's okay. So they have. It was 10 cars. Yeah, you'll probably get good. Yeah, you saw it. All right. Yeah, that's, yeah, you have to, plus they have to, if they want to correct somebody, they're going to have to. No, At Kate? Yeah. Oh, yeah. Are you? Oh my God. What's that? Oh, okay.
And that night I went back. How was your knee? I forgot. He's been there almost a year. Longer.
Yeah. Yeah, you know? Yeah. I think went back there.
You have paid.
Yeah. After what now?
Not admit that he was. The other kid who played was trying to get federal covering up my phone.
Well, with the oldest, are you going to the staff? William Joel, she's a biochem major. She's I think she is actually. That's quite a few. He's really good. I made her surgical.
Good morning, Karen.
You? Yeah.
I did
Better than yours, I think.
I did my business therapist. I just don't worry.
I might. It's not the, don't know.
Good morning. Networking's great, but it's not. Welcome you all to this meeting. And we appreciate your thoughts. Have some great discussion throughout the. In the interest of full disclosure, getting over pneumonia, they have a coughing fit, they leave the room, not for lack of interest in the meeting or the content. It is. So far I'm doing okay. I want to be sure to thank the MDA for providing today. Thinking we had another funding source for came through for us, so thank you for doing that. We will have lunch at about noon. So
If you don't like it, you gotta yell at Gary.
actually, and also we will have patients. We did have to scramble. So, amazingly, pretty quickly. Honor that. So we scrambled around. We were happy to get this location. I think we ought to maybe just go around and ourselves to start off with, and we'll.
Hey, I'm Dr. John Daly, State Dental Director. Thank you all for being here.
Julie Beckman, I'm the program manager.
Laura Haygood, I'm new.
Camp from the Dental Science Center.
Angela Fuller. Abia Oka, Majara pediatrician, and also the Missouri Academy of Pediatrics.
Melissa Van Dyne, and I'm the Executive Director for the Missouri Rural Health Association. Lee Witzig, I'm with the Department of Mental Health, Division Director for Development, for Bowden and State.
So that's Dr. Wanda.
How do you feel, Dr.
Scott Clardy, I'm the Deputy or the Assistant Director of Columbia Boone County Public Health and Human Health Missouri Association of Local Health Agents and Missouri Public Health.
I'm Karen Dent. I'm the director of the Missouri Primary Care Association's Oral Health Network.
Vicki Wilbers, I'm the executive director.
Michael McConnell, faculty.
Dental Hygiene.
Good morning. I am Ashley Herman. I'm the Outreach and Project Development Director with Missouri Coalition.
All right, thanks everyone. We'll have obviously join us. And for us, so we probably some pragmatic things. There is coffee and water in the room here, restrooms back out to the front, and if you go across. As I mentioned, we'll break for lunch at about We are recording this meeting primarily for note-taking purposes. The recording's already run on. I don't think it will, but it's mostly in. Very much wanted this to be one of the other meetings. They'll rather have you in, but that will be available. It has, I think, one person who might be calling. Very much wanted to be here in person. And then there's one other individual. And it all, and so that recording. Okay, just in terms of a quick overview, we are working on the existing state oral health plan, which I'll grab a copy of that, and we hope that you read it. These meetings based on the assumption that clear with the plan. Our copy today, we will display the goals and some of the stuff below. But it is based on the assumption. So we're hoping 3 meetings, but I do not anticipate we will walk all the way through the plan today. Melissa is a note taker. She may have a few clarifying questions at some point. We recognize that there may be issues that are brought up that do not fit cleanly in structure. That may mean some more things that fall outside of it. The plan is very much about state operations, setting the priorities for currently the Office of Mental Health activities. So it's not, some states do oral health plans and say what everything we need, suffer from a lack of focus and prioritization. It's great to get those kinds of things down on paper, but it's a little bit hard. So it's a little bit more of a narrow. There may also be issues that are more of a policy nature that come up that would not necessarily fall to the office. Maybe things that come up. By the way, we are delighted to be. I think that's all I have to cover at this point. So since Dr. Williams is not here, Dr. Zane is going to give us a overview. Slides on display. Yeah. Yeah, maybe don't, but I can.
Well, thank you again for coming. I did speak with Steve. Other things going on in the state besides us today. So, my voice may come and go. Let's give you a little bit of I could stay up here and talk for 2 hours about things where I'm not going to do that. Make it lucky stars. However, we do have some reference issues. We have some asked and but this is their oral health plan. My hat off to it. 2014, been here and did the same thing. I was in the fall of 2009. Ways to do that, and I don't think do same types of things as those are for all day meetings. Because Missouri had never had it. I think when you look at the issues that and we have 6 full-time employees and part-time employees. We have myself, Jackman, Callie Klein, and Laura Hager. Health program representatives, 3, each one of them have their specialist. Callie right now is doing Young Smith is our new started gender sheet. We've needed to have our own day one. 3 different sources. We are in the process of hiring a research epidemiologic items, all the positions there. Our oral health consultants work for the PSP program. That's Cameron, all registered dental hygienists, state employees. That means that we can schedule hours flexibly up to 1,040 hours. Now is also support. PSP program does a lot of screenings, 90,000 for the school year, but it has to process the database. So we have some major programs and a lot of minor programs. The Preventive Services Program is the main program that we do. It is funded by MCH Grant Fund. It's across the state. Fluoride varnish at the time of the screening and then later. We started with the 5,000 plus kids in 2009 and kids this year. Schools, a lot of effort, coordinating.
Yeah, 6 when the program
2006 started, okay. And it helps to have institutional memory. But, still, I talk about going to other state dental directors, they stand go, really? It is important that we will be having a research paper coming out this fall, we hope, HD, West Missouri State, that get interested in recognition. So, told us that she's talking about cancer detection, and Carrie's experience. Dental Sealant program, funded by Delta Dental Foundation. It's a 5-year program, the first part guarantee, last 2, and 2 5 months. Just coming up at the end of the 3rd year. Crossing our fingers if we $200,000 a year. We have 4 contractors, 2 county health departments. Latest total on it. Yeah. They've been doing a good job. Could we have more? Sure. But it takes money to do these. That would be out there. That's some reporting on that later. With fluoride varnish program, we did a pilot study last year with the county health departments. They provided fluoride varnish. Children that participated. Being very as a success, hoping dedicated. Oh, that was your demonstration project.
Look in my direction.
Yeah, I looked in your direction. We have, course grant that received last September, and those of you that know first year, all-year grants are contracts, RFAs and things like that, out to get things processed. We are at the point of getting the health industry. The tele-dentistry, I'm familiar with it, very similar to telehealth, medical specialty. In dental situations, asynchronous type of thing, or dental hygienist, and x-rays, photographs, and chart that is transmitted to the diagnosis. Dr. Williams?
I'm sorry,
Everybody that- Thank you, Dr. Williams. Special director of my boss. And,
But in the end, it's a practice. What you're doing is incredibly. That you have to improve our work. As we just do. Sorry, we are on purpose. Second thing is interest. What do we do? I agree. I think dental care is, and the way we look at this is that and don't get it.
same time, I think that alternate factor, he lives and more densely county. So if you really want to track it, houses. So the rest of the world doesn't look. They go nowhere. Any warning somebody going, hey, you know, bad food you want to eat. What's wrong with this model? Even though the rest of the world doesn't do it, what could be wrong with this model? So my point is, Todd and I believe fervently that we'll follow Medicaid. That we have to get to a point where we're not spending all this money on insurance. We're paying dermatologists $300. It makes $325 at a family practice. We have to move toward prevention, Medicaid dollars, and as we do that, we have to pay for those. One of those is poverty. Ferguson. But full conversation. What do we do? That one. And we think and looks at person. Average life. Everybody in the country. The doctor Bible says, go where we're needed. So I'll stop there. Let's try. Global health, dentistry. Time, just pay people. Don't believe me. Already London. Parts on that different operating. They work that way. How we approach health in this country. Very much information. We're like. And I'll get paid for them. They won't. We have a very outlier view, by the way. curve for the CDC. Curve goes like this. Longevity. Cost. That's the curve for cost. Longevity is what it is. In the last 3 years, the average. Right, doing better. Yeah. Don't know if you notice it now. Let me stop changing. Crowds, late. Bet you can imagine one. Dang, I'm going to last. Hello? I don't know if it's a funny story or not. I'm talking to me. Sure. Watch this one. Look at friend of mine, Steve Roberts. Walk out. Go off to the center of revolving. Facing. Don't think it's an option. I think that's a pass. I guarantee you. It was one. Wasn't part of a careful calculated. And I'll always remember. Steve knew that. That was the funny part. But he knew there was more evidence. Proud of it. I'll be glad to answer.
I have one comment. Thank you for coming and sharing your time. I was at a meeting. General. His new oral health report is coming out this fall. And the biggest emphasis.
Yeah. And you know, Jerome's a dear friend. Yeah. Here we go. As you know, our tradition, I have to start off this, but my phone number, you're welcome. This may be a habit. I go to bed at 8:30. My phone number is 919-413. Yeah, he says. I write it down. Yeah. And doesn't that tell you something? Sugar tells me 3 seconds. Just like that.
Mine too.
Anyway, back to the best color. Elements for seal project, the other item. CDC doesn't pay for education. Health industry, offering there is some equipment. Community water fluoridation action committee is also part of the additional efforts, patient outreach, planning in this room, action. Coordinate that group, got a lot of opportunities there to be. Let me get some minutes. MBA. So we'll have a broad base. If you're all familiar. Different videos. And they'll see the promotion. Again, PDC doesn't pay for by the impressions that I have, we haven't done a study on this yet, is that there's a lot of this. It is considered standard of care by Delaware. But study was just done in South Carolina. They found that 45% of the Charlotte County had dinner residency. When they only had 22% kids receiving. That's kind of by the way here around 20. So national average. Goal is 45%. We'll see. We have some opportunity, but we're going to look some more into dental sealants, why we are where we are out there. Current projects, community water fluoridation training and education. Those of you that were at the session, I have a slide on course that you log on to. There's 6 modules. The first 3 modules are intended for anybody, anything. The last 3 modules are operators. Now, did the last 3 as well, and that's just how to do fluoridation in your water system. It's interesting to see how these things work inside the water department, what kinds of things are going on. We put a lot of trust, a lot of pressure that are water department. They get questions from people on the outside and people on the inside about stuff. But we can all use process of trying to get credits for dentistry. Dental sealants, the Dental Foundation. Place right now. We're going to continue to try to find more funding for dental sealants. Past has funded dental sealant projects. There's money on the horizon right now. Ways to work. We are HealthNet. We have ways to applications. See what happens. That's the turnover of staff in the group that we're working with. That we are having, if any of you are going to be going to the Missouri Primary Care Association meeting. Speaker down there talking about paradigms. We are in dental school, dental hygiene school, repair, or as a cleaning and fluoride thing. Not much research evidence shows that polishing teeth with thumbs actually carries polishing dental seals and fluoride. Teledentistry, teledentistry have opportunity projects each year. Next 5 years. Services program has been growing. Our goal is to reach 2,000. We've had some blocks in certain school districts. For whatever reason. School district. Yep. With them on a few of their schools. They don't have a good experience with us and get into the sprinklers. Follow up on that into the world. We've had large school districts like St. Louis School District have limited opportunity. Gather data and provide things right.
Have some of the districts just flat out opened up?
Yes.
Larger, smaller, middle,
Yeah,
all?
Springfield's a huge district, and to have them not want us there, it's not that they don't think we do a good job, or it's their process. They have had a very good process, they feel, treating kids, but they don't share any data. It's all internal, and
Something's being done there.
there's something being done, and
We don't know what though, right?
yeah, we're not sure why. We did spend, and all this effort falls on the shoulders. They try to, all their screenings, vision, portfolios, and do that all. They've had reasonable lack of getting participants. Don't do that, so we're our thing captures. And the same thing holds true. Yeah, so many people asking that opportunity. Program evaluation, surveillance data history, big deal, CDC mandated evaluation plan done in them, so we do, and we have, and basic screening surveys for children older and disabled. Can I say we've got a database?
We are one school short.
Cool.
Yes.
Short of having the database for greater. And the problem is that they did it and they mailed it, and we never have gotten it.
So literally, they told you that.
Literally told us. Once we get that data, then we'll do an analysis. AST. Funding. Grant funding provides for all of for day-to-day operations. Have any budget for the office? A piece of time, salary, a day a week, whatever review. Good news or bad news that is the football is I think because of the fact that
The funding for block grant looks like, I know that, the funding for the block grant, is it steady, is there, you know, for a while there, they were taking cuts at that, the entire block grant.
our block grant did shut in. Reduce our funding. They haven't come back last year or this year. That's the budget cycle just started. General revenue funding, eligible bill. Donated dental service, which lifeline. Got a little bit of big. Versus the Missouri Foundation for Health and Health Board Foundation funding for the cell dentistry demonstration projects, fluoride varnish program, and none of yours. Or that our county. Beltsville Foundation program, personnel services within the PC cooperative agreement, water fluoridation bills, promotion, forest positions. Tallies. Preventive health and human services funding for fluoridation education, health officials, policymakers. SCH, the services program, does have office portion of tallies. All 5 or 6 different ways. Do a little bit of a SWOT analysis. Yeah, I promise you I wasn't going to hours about data and stuff like this, but our strength is a small but committed staff. Very good staff, a lot of them dedicated about what we do. They're looking forward to having it. We've got very good relationships, great relationships with our stakeholders. We can get anything done that our stakeholders state. Had contracts with all 3. Get things done. Stable money for 5 years. That's a cooperative agreement. 5-year grant to help create some stability in the economy. The PSP program has provided data for 12 years. That's able to sit down on my computer and go back and look at PSP. Tell me how things have changed, what impact that program has had. And over the years, we've actually reduced the decay rate by 4%. Last time I looked, last year. That's tremendous. But saving money. That's cavities that didn't need any. These didn't need to be filled. Paying that care down the road, that counts for the dollars. That's very worth the investment. weaknesses. First one, right from the last one, it's also a weakness on, we could use 15. But, we work with what we've got and try to do things that money provides for present activities, not much growth. But growth programs, we'll either have to cut back from other programs, have to find more money. Reach to the choir out there, I'm sure all knows how that is. Good resources, opportunity, funding, If you look at the funding, say 5 years ago, regular funding opportunities that came down the pipe, there was a lot of emphasis. Sort of foundation had a section on oral health. Oral health. So hopefully, there's a general report coming out this oral health funding area. It did back in 2000, out back then, and just put dental health on radar. And we need to do a better job of interactions, but spend a little more time and find a better method that we don't do it to celebrate our victory. Things you all will help us find a better method. Opportunities. Again, I mentioned at the start that all the areas of interest are still areas of opportunity. The actions that we may choose to emphasize under those areas change landscapes. So, situation challenges have changed. 5 years ago, we only had one dental school. They have a third dental school.
We'll have a third one. It was announced Tuesday.
Okay, so we're going to have a third dental school. Back when I was in dental school, and we were in St. Louis one. So we'll have one in one in Kirksville, St. Louis. That's big news. We ranked 41st in dentist population compared to other states. Randall was just up here talking about distribution of physicians. But you're a dentist, you practice in 4 areas. Columbia, Jefferson City, St. Louis, and Springfield. Over 1,000 of our 3,000 dentists practice. Talk to Reese's office, 99 of them. I think that's good. 23% of the 6 to 12-year-old children have steals. It is 44%. Big opportunity. 37% of 6 to 12-year-old children came. That means that they've had cavities, they've had the opportunities, they've got filling, or maybe extraction. 22% of 5 to 12-year-olds had none. And you could say, oh, that's all rural kids. I was surprised. We looked at the data on that, and it's almost urban and rural. We did a study with the ADA 2 years ago, and the patients that were seen in the city of St. Louis. Take one census tract right here that had high need, high dentist utilization next to a census tract that was high need. about the, action. Anti-fluoridations are a threat. We've been told national stage that, and part of the reason is coming conservative nature. Most reasons why has to do. I call it the libertarian side of things. It's the same issues with vaccination. That for a time. Decreased funding, local, state. At least last year there was a big concern with the CDC. Sent us out stating that right there, full time. Guarantee. Budget. Well, decreased, but it hasn't gone away. And agencies, statewide agencies, government funds. They have a lot of money. Medicaid folks. They got the presentation by one of their dental folks out there yesterday. They have as many people Medicaid. We were blown away by that. I think that we got 6.5 million, give or take, in Missouri, and they had 5.9 million. Maybe that huge budget they got is enough. Complacency by providers, dentistry just not on the radar. To be honest, a lot of dentists concerned about their practice. Their ability to provide care where they are. Get downtown. They think that that new guy almost, yeah, he should go to. That's kind of the overview. Going to be here as resources. One, hope that you all will dig into this. What we want have limited resources, know that we have big problems. We want some input from you folks as to where we should go with this. Now, if you look at that document and where there's so many activities in there, all of them worthy, every one of them worthy, but we don't have the staff to do every single one of them, and much less report on every. Add things you think are important, and then help us with prioritizing. Thank you for your time. Give folks a 5-minute break here.
Sure, that sounds like a great idea. So we did have a couple.
Consider former director of country, director of the health center, health industry program.
Sorry you didn't get the email. It's about to change it. Worried about it.
I thought you guys all had.
That's bad. We hope to get that location. Great to have you both with us. All right, we'll take a 5-minute break. break, again, there's coffee and water. There's a break room there, bathrooms are 5 minutes, not 10.
I'm gonna ask them.
Baby shower. Did you really? Yeah. It was your track, right? Oh my gosh. But it was great. We're having one. Yeah, Harry, you might. That's good. That's the truth. Yeah, otherwise.
Okay, so we're gonna go ahead and get started with walking and what needs to stay, what types of activities. Where do some of these goals need to be changed or removed? So with that, we're really looking to, again, evaluate the goals and activities, have discussion around activities. Again, Melissa is capturing, so if she does have any clarifying questions, she'll just throw those out to us as we go through. From there, we are going to take the conversation and notes from today, start compiling different themes, different ideas that are coming from today, and that's what we'll bring back in later meetings to then evaluate and start building consensus of what does this 5-year plan look like for the state of Missouri. So any questions before we get started? I hope everybody is ready to discuss. You've all had a chance to go through the entire plan. So with that, we're going to go ahead and take a look at goal number 1, and that is to identify, investigate, monitor, and report on oral health severity. So I thought we would just kind of keep this a little more open. Whoever wants to jump in first with kind of initial thoughts around goal and activities through the plan, anything that really sticks out to you, things. Fairly somebody has thoughts. Yes, Diane.
Goes in with what they had said before, that you're looking at the three public health functions, certainly assessment and identifying, monitoring, that would be part of that. This seems like as a basis goal, it should be kept as a part of what the Department of Health should be doing.
So making sure those guiding principles of public health are captured. So
That's what I'm going to say, yes. And this one would capture that.
lowest geographic level available, Dr. Ding, correct me if I'm incorrect, is that looking at county level, depending on the type of data set that we have available?
Data sets that are out there are variable depending on your and get that Medicaid, while they can do this code data, chances are any data we get claims data. It's just so it just depends on the source. There are opportunities like you get 88 special situation. Others lower you get.
What thoughts do we have around identifying and investigating oral health problems determined?
Well, I will say a couple of things. You're doing the basic screening surveys for basic program does across the United States. That data goes out. That was Robert.
I have a question. Was the idea behind this plan try to capture everything that you guys are doing and stretch, or was it to just stretch? Because some of this looks like things that you're probably routinely doing anyway, so I wasn't, I've been in several strategic planning sessions, and some of them are just about, we're doing what we're already doing with the strategic plan to stretch, and I just wasn't sure.
The answer is yes and yes. If there's areas we need to into, that's the kind of things. If you look at this and say, you got money to do that, that's nice, but I don't know that, with your resources, I'd rather have you work this than. So this is kind of generalization. A lot of these things doing in 2015
Okay.
that we have been doing. So that's my impression. I wasn't there. I think you were there for this or not. But my feeling was that they were looking for something wide ranging across the board.
The coalition strategy around, we thought the state should do to be whatever data that is available should be collected and reported. So yeah, I think that was the intention.
What data does go into the oral health?
I would have to pull it up, but we do talk about things that we look at in basis. Those things go in there. Then there is data about Medicaid. Service, early services, diagnostics. Total number of children receiving. Look at oral cancer rates that the surveys. They should be savings.
Yeah.
No, I don't have anything specifically from the managed care folks. Any data I get from Medicaid. As data from last year. So, yes, I did. Whatever they get.
Okay. So we're not sure if there's gaps there.
Oh, I'm assuming there are gaps. But, you know,
I'd be happy to. Check that if there's.
Part of brings up activity. Goes into activity. This is one of those actually.
brainstorm.
What anything, that sounds like it costs money, but at least having discussions of how can we evaluate in the next 5 years ways of modernizing the reporting. Things would follow, like,
Have said they're pulling up Facebook page maybe.
maybe that is not a bad idea. It's not, it is kind of hard. How that stuff. Increase. Maybe it's just the find stuff. Ways either into each other or they're next to each other, or whether the updating is a regular schedule. I know different things come in, like things are different timelines that happen. Modernizing, being more cohesive about all the stuff we get, the only ones. I mean, one thing is, I don't know if now is the time to talk about it, but on my short list, goal of 5 years, 5 years have a plan to, have to hit paper and talk about it. But this is the place to say, that or just later on, we talk about it.
We're working on that. We've done a survey and where you could do a pilot, we talked about doing a pilot with an app that you would complete the screening. So, we might be able to talk a little bit more about that.
Yeah, we tried a couple different things, Survey Monkeys, an app. Yeah, we're ready to pilot it, we just need to find some willing. But, try it, and so, yeah, we're ready.
Because of their Wi-Fi access. I think that was brought up last year. So I was wondering, if I'm going to put you on spot. Might be a place. Perhaps. Section of maybe something just for department to put out.
Oh, I can't imagine why not.
We'd be happy to fill that one. Actually, I don't know if anybody else does this, but what's that?
Yeah, and we do the same thing.
And people aren't wild or crazy. Otherwise, it just kind of happens. Not the only program. Start tweeting, taking over.
That's Irish thing.
Social media is tricky. Ridiculous.
These are the conversations that we want to be having. I want to jump back to. Right. So the point of this goal is to state that the oral, right, I had it in my head. So the office that you guys, right, thank you. The goal is for you guys to get all the information, disseminate it, and present. Once it's presented, where does it go? What happens to it? Is there a point in this process where once the information is collected, you can make some recommendations? Because as I was reading the packet here, there was something that really stood out to me. Some of the statistics. Missouri has a decrease in dental visits, a decrease in dental sealant, has an increase in tooth loss, increase in oral cancer, but it has an increase to access to community water fluoridation. So that to me is like a huge gap. If we have great access to fluoridation, but all of our decay and tooth loss and things are still down, that information and having a way to assess it and disseminate it, come up with, active ideas to kind of close that gap. I don't know if that would fall into this category per se, but I see that we're looking at data, we're monitoring it, reporting it, but that's it. That's what we're doing. Is there another step that we can have as far as like follow through with the data to make sure that this is positive and going somewhere?
That's the one of the frustrations that I've had. Thinking process is a lot of things. We don't have the funds to directly affect it. Policy. Mitigate these. Activities. Or legislate. And so I turned to Carrie because I can't allow it to provide information. There, provide that information. Medicaid. The way we things. Having fluoride first. And it is. That's one. Providers. And younger. Exams. Yeah, these are the kinds of things that brain trust folks.
Maybe it's adding like implementation of the data or to have a way to implement.
Talk about this at the time. The gathering data is the first one. And this goal is probably put in here because it's data first. It's written to about premise. We're able to find out about ER visits. Actually, there, it didn't happen. So,
bones now.
Yeah, I
No,
think maybe formalizing the data collection. There are maybe available, maybe a scheduled time where the group comes together and look at it and figure out how to. Twice a year. They based off the right, and then occasionally things that are happening. What can we do about these zip codes or this? What is a good zip code? Right?
So it sounds like we're starting to get towards a good portion of the collection component of this, the assessment component. Now we're starting to look a little bit, what do we do in terms of analysis, evaluation? Kind of what I'm hearing. Michael, did you have a?
This was related to activity 4, which looks at the workforce. Since this was put together 5 years ago, whenever, there has been a change in the sense that there now is legislation which allows each of the licensing boards to contract with, in this case, it's actually the Office of Economic Data Analysis at MU, to develop a minimum data set for collection with regard to workforce as part of the licensure process. They've done that with the Board of Healing Arts, they've done it with the Board of Nursing, and I don't know if anyone has seen it, but there's a very robust report on the nursing workforce that came out of that collection process. The dental board, to my knowledge, has not yet signed on to that, but there is discussion going on, and I think Dr. McCunough has been involved in that to some extent. It really seems to me that as a step forward, collaborating with that effort for dental and oral health data would be very helpful because it puts it together in a statewide database. It works it together with other health professions as well, and it gets us to the point where we may well be able to report much more robust data. I think if the oral health program collaborates with that effort, helps to try to move the dental board as possible to collaborate as well, and begin to produce some data out of that that gives us a really good picture of what the oral health workforce looks like in Missouri. Then we can start looking at what impacts different new dental schools, et cetera, have. Because right now, we don't really even have a very good baseline to get that. Well, we've moved from, I think, saying that perhaps the state should, that the oral health program should collect and do this, so that we ought to collaborate with what's now going on with the licensing boards, with the others, to make sure that we end up with a statewide, robust health workforce data.
I agree. We had a meeting with Brian March on this very subject. The last workforce study was done in 2004. We need, I mentioned the nursing one, I didn't know about board. And he said that, at least in March, that the board was probably not going to look at doing that because it's very expensive. So we have questions that will go out 2020 that we're talking about now. We have to share those with you. Questions? I, for one, love to have them do that. Really, we have 3,200 dentists in Missouri, about 4,400 hygienists. Size of the population may not be big enough. And talk to your members personally, you know, or the other professions. Again, I'm not the decision maker.
Well, and that study would make up.
And
When you look into that, you don't actually
And the history with this is, it was built a model of the Shep Center. That's what this whole thing started, was that model. Because if you go to the Shep Center in North Carolina, look that up, related to work. And that was what we were trying to accomplish.
Yeah.
Which it goes back to the whole forefront. That's develop policy and then go that's digital policy. I agree that with potential new practitioner models and stuff.
And I think long term, it helps us to have an integrated database that looks at all health. Talk about the interplay between medicine, dentistry, et cetera. Right now, we don't have that. And we're beginning to see, I think, some of the smaller boards, pharmacy, others, that are actually looking very favorably at moving. I think at some point, we still need to keep pushing the dental board to do that. Yeah, it costs money, but anything worthwhile costs some money.
And at the educational level, we have pharmacy, medicine, and dentistry have new accreditation standards. We have to do this professional education. There is going to be, but we're not really discussing.
It sounds like there is an opportunity here around that activity. Standardization, collaboration amongst the different boards. We've got that.
Also determine what dental professionals are interested in doing different things. Like some who might be interested in doing telehealth, but they haven't been connected. Or someone who wants to maybe work in a rural area, but about finding the people where they can, or a place where they can work. It just seems like we need to get messages out better along with this, the distribution problems. Maybe we can get people to these areas. But if it's a matter of just not enough, that's a different issue. So it just seems that it has to go a little bit further than that. And maybe those questions on the dental board survey would have something to do with that. And then, and I think also along with that, the communication that we were talking about with the survey information, it should go a lot of places. We shouldn't just have it on MBA or the coalition. Other people might be interested in this, and they maybe send it out, have the press know about it. More ways of getting information out and know where to find it in more than one place. Because somebody else is not going to look on, the Coalition of Oral Health website, or they don't know how to get on the DHSS Oral Health website. There's got to be a more basic place to find this stuff and let people know, and that's what I think.
Sounds of the information sharing and dissemination could be an opportunity moving forward for this goal.
Saturday, talk about the press release. Items throughout. Anything within the department. And I'm sure.
Well, you can cheat and ask us to put it out.
Yeah.
The thing about press release is they're always looking for little bitty papers. Now, whether or not you can listen to it, there's a question, but I mean, if you want to get more. And I think social media does help. We have a fairly large footprint. It's over 12. It reaches kind of over 12,000. The trick with data type things, you want to have kind of a pithy little one sentence thing that gets people to pay attention. We can do that. We don't know how to do that, but just start using photos. But the thing is, you can do that kind
around the
Are you guys doing, Facebook and Twitter, or are you also?
Facebook and Twitter.
Or if you're wanting to get some general program of payment.
My niece tells me that Facebook is for old people.
Yeah.
There is an issue with that Instagram story. Popular thing, I do have to say, I would have some questions. Activity to generate much of that, but I mean, certainly legitimate to talk about.
These are good points to think about as well. Remember, when this plan was originally talked about in 2014, 2015, a lot of these social platforms were not present. So with the evolving times and bigger imprint of social media, having this.
I know. Starting of, doing camping and, director. And asked the college age students about handle. You know, so, yeah. Facebook's wrong.
Other thoughts that come to mind around this goal and a set of activities?
On activity 2, the third bullet, monitor oral health status among individuals with chronic diseases, disabilities, and other cofactors that adversely affect oral health. We work with community health centers, and our populations that we serve has a greater incidence of chronic diseases and comorbidities. And we have trouble assessing exactly how their oral health is affecting their chronic disease outcomes because we don't have data on it. So we've been thinking about ways that we can possibly incorporate data collection, those chronic disease primary care appointments, and maybe using teledentistry to embed a dental hygienist in primary care practices in order to not only collect that data, but provide oral health education, collect records to transfer to the dental clinic, and get those patients referred and assured that they actually get a dental appointment. So I think that's something that we really need to consider. We have an aging population right now. It seems like community health centers are dealing with more of these chronic diseases than maybe the general population, but that's probably going to change over the next few years.
The more opportunities around standardization for measurement of oral health status.
Right.
The integration of the.
Right.
And I had a question, I'm sorry.
Okay. Is there not a program already in place through Medicaid that's like a bridge between medical patients and like diabetes or heart disease or diagnosed with a condition that they can go through an approval process to have their recare paid for by Medicaid at a shorter interval?
No.
Oh, that's great. I thought
Short answer to that is no, but,
because at my S2HP, when our new hygienist came on onboarding, they had discussed some program, and it's like a wellness dental home type program, where if they are diagnosed with these certain chronic issues, that they could sign up through Medicaid through a process, and I can find out more about it.
So would they be talking about health home programs?
Yes.
Chronic disease?
Yes.
Individual.
I think that's the point, yeah. And
But
like,
I don't think it was directly tied.
it was like once they're diagnosed, that they could have
There's
their.
a medical referral exception for patients who have chronic diseases that are directly impacted by their oral health status. with a medical referral from the physician, they can actually access comprehensive oral health services through Mill Health Net.
And it was like they can have their recare twice a year to help with their chronic.
Right, and that, we don't think that's utilized enough. We try to educate our providers about that. But in terms of this particular, what I was mostly referring to is kind of kill two birds with one stone. Collect that data from patients who maybe are not getting those referrals, but if you have a dental hygienist in a primary care practice, and every time there is an appointment for a patient who has a chronic condition, that dental hygienist would conduct a screening, would provide education, and determine whether that patient needs a referral if they haven't seen a dentist in a certain period of time. And also collect the data that we need in order to demonstrate the impact of chronic conditions, of oral health on chronic conditions and their outcomes.
Just to piggyback on that, how many dental hygienists work in primary care? Do we have data on that? And is that something that we can follow to see if because it's a great model, and I think hopefully over time it would expand even into pediatrics. It's probably talking about adult care now, right? But I was wondering I wonder if you have any data on that. Maybe that's something that we can track as well.
Yeah.
I'm sorry. I was sorry, I don't speak very loudly. I was asking how many dental hygienists work in primary care, and it is that very few. Okay, so it's very, very minimal. Okay. Yeah, because I think it's a great model that probably should be encouraged across the spectrum, right from pediatrics all the way to the adult care.
Primary care office. Purpose agreement is had agreed to our kind of teachers and workforce shortage, we stopped doing that program. But it can work. But also in Arizona, they just passed the law, the governor signed it. And it's working.
Yeah, the part of the barrier to that was that how do we pay the dental hygienist? They couldn't bill under those circumstances. Now in teledentistry, they would be able to. So it's something we want to encourage, but we want to make sure that it's a really well-rounded program that includes data collection that can be sent to the state and, utilized.
Perhaps another opportunity for that assessment of capacity of the workforce institution.
Well, kind of goes along with my first about, what the same bullet points you were bringing up. We're talking about monitoring oral health data, chronic disease, disabilities, factors. So I guess was that not happening 5 years ago?
It's limited in what it's doing today.
It just seems like, I was surprised to see that in a, so, but if it wasn't happening 5 years ago, I can. It's kind of like what Nathan said earlier. Yeah, we're monitoring, but what's the, so that helps explain that.
Part of it is software. Dental software does not talk to medical software. They talk about caster. It doesn't have it. I don't really understand the why or wherefore. Not something. Our side, it is definitely proprietary types of things that medical software doesn't want their code getting out to other companies, vice versa.
What we've heard is it's not cost effective because other than community health centers, you very rarely have co-location of different health disciplines and an organization. Right, so we could get every FCHC in the world to adopt one software program, then we might have some leverage.
we have to do ICD-10 codes that link their periodontal diagnosis to their procedure codes, and it's all built. Would there be a way that they could, a code that if you come to me as a dental hygienist and you have diabetes, high blood pressure, that I could document those things in your medication, and they should take that information? Right? I was gonna say something. Thanks a lot. We don't specifically report like any chronic conditions, but like they do have to link an ICD-10 code to any periodontal related. And that's how they report that. But I don't think it overlaps. Dental is doing medical. Ours.
Well, what I can say is that they're very much trying to encourage that through all of dentistry. But it lags significantly, and, you know, when you have practitioners across the country that are so used to CDT, having an ICD-10 code and a CDT code, it's going to take a long time for that practice to really filter down into, I think, into the dental community. But I will say that ADA, there's been articles about it, there's been pushes about it, because what we're even hearing is if there's an ICD-10 or ICD-10 code, maybe even prior authorizations wouldn't be necessary to the degree they are now. So it's just funny because Dr. Dane and I had a discussion about this a few months ago, where I said, you know, there's going to be pushback on this.
Oh.
But it, yeah.
Came to video.
Sharp riders do that. On it, yeah.
There's a box there, but,
Just like we fill out oral hygiene instructions. I don't know, I understand like all the different platforms of software and having to add in those. That would be a huge.
I'd say until it would be a requirement. So,
there's,
something to
you
think
know,
about.
okay, you probably link to private practice laws. No reimbursement, that there's no incentive to do that.
Yeah, right.
All that stuff. You're going to turn and walk into that.
This will come up, I think, later as well, but there's one very specific bullet under activity, detailed demographic data in order to describe disparities. I would just add in that sentence, if we're going to keep that sentence, and other social determinants of oral health. And I think we need them to think about later. We talk about getting information out to dental professionals, et cetera, much more emphasis on what they can do with relation to social determinants of oral health, not just the treatment of the dental disease, but what else we can potentially do that will make an impact.
Great point, especially what we heard in relation to the Surgeon General's call that those social highly elevated within that report. That's a great comment. Discussed quite a bit around goal 1, but there is one piece for our typing action. That way, that is relation.
Well, if we're keeping any of these bullets, it's the second bullet under activity 2. It talks about the demographic data and disparities, and it clearly is referring to, as well, social determinants of oral health, but I don't think that terminology much. I get that.
I was going to say generally,
Right.
emphasize determinant word disparities. Then there were several. I don't think it.
The one component on this goal that we haven't touched on is activity 3 in regards to assessing
water fluoridation status, and is there any discussion to be had around that?
Public health, or from a local, those, just like, those fights are, and, if it had Gary and side, we would have lost it. So that's something we have to stay on top of. The most preventive activities we have. I think it just needs to be emphasized.
Well, and years ago, we didn't have the reporting, keeping track of who's considering making those changes and being able to address it.
Yeah. Exactly. Kids with authority have an average service, two services a year. Had filling done in the office years. Yeah, dental insurance, dental insurance, 80%. But they don't have that. Got 4 kids, or they $1,000 a year. And if you even take your kids. If you take your kids. They talk about this all the time. Most people don't have $500 saved for a person, and $1,000 for they have a positive impact. Their independence. We do annual report of the office right now. Last year, because we report to something called major tendency. Water fluoride, and check to see what your town is doing. .com. And as a customer of any water department, statement of water quality, most of them also. Average water.
Just following up on the cost of dental rehab. I wonder if it would be possible to track the youngest kids, those who are less than age 5. I know a lot of the data, wonderful data that you present at school-age kids, because we see a lot of kids who come in for pre-op dental exams and have to go to the OR for extensive dental rehab. I don't know if that statistics, if presented, might make people feel how bad the problem can be, number of kids who actually have to have dental rehab under anesthesia below age 5. That might be a good metric. That might open at least my colleagues' eyes, Yeah, and I feel like some of these metrics may apply more to certain professionals than others. I know that if you want to catch our attention as general pediatricians, that would be something that we would look at again, or number of kids who have fluoride varnish applied, or number of kids who have all their dental services collected in a particular year. So you might consider, and this is under dissemination of data, disseminating data that's more likely to what we paid attention to, like maybe to a professional body and say, well, this is what's happening in your area, this is what's happening to your patients, That might be helpful, I think.
Looking for data that's more cross-cutting across different sectors.
Yes.
I know that Bob does look at
does, okay.
And, I could, all I hear much.
It's too much, right, it is.
And how can we reduce it? But, yeah, I could get, figures for it. Yes. That was out there. That was one of the ways that we were able to get silver iron chloride added to the procedure list. North Carolina, so it showed that they used their
I see.
Being able to have some of that data, we can start to build cases for particular components. Additional thoughts around goal 1?
The only other thing that I would mention here is talk about disparities. I don't know if anybody has thoughts on ban disparities. And are we capturing all the data in the whole population? That could be. Now we're questioning, race, kids education. Actually, that's maybe possible.
Actually, much on periodontal.
Yeah. I mean, other than claims data through Medicaid.
I really like to see more of that. CDD, and on that, or there's some kind of study that was done a few years ago when I went to the oral health. Finding a way with the status of periodontal doesn't, yes, I don't know, just probing or if they did some things with telephone interviews or what they did, but I think that that's really important, and most of our, adult patients have some form of periodontal disease, since it has such a huge impact on teeth. So,
one of my issues is that there's only 6 pregnant patients that have that.
Very well. I had a 19-year-old girl in my chair. She just had a baby a week ago. She tried on her own to sign up for Medicaid. She was denied because she didn't have the resource to get with a coordinator or someone. And so she missed out on Medicaid. Now she comes to me a week later with a newborn baby, and I'm like, here's our coordinator, let's see what we can do for you. She says, a week ago I could have gotten signed up and covered and everything. Now you've had the baby. I don't know what I can do. So there's a huge gap in navigating this system to be able to get people signed up to actually use it, unless they have access to a coordinator.
Never had anything like that.
Yeah, like I said, at our FCC, we have 2 people that's their job is to help people. Yep, she didn't know about them. She didn't know about the resource until she came to the dental office for her checkup, and I led her down that path. So I think they should be able to help. But it's a common thing that I see reoccurring in my patient pool is that they didn't know that they could qualify, or they tried and they figured it out on their own. They just give up. Just feedback, that's all.
Great discussion.
Right. Is there a data source to get at that is clearly part of the determinants of ability to get care? I don't know if that's measured anywhere or collecting that type of it.
There's an optional question. Have to look at that. Optional questions, you have to pay for.
That may be one of those questions. Are we making?
John, is there anything in the new duration of healthy after the stress?
I don't know, I haven't seen. Okay, yeah.
Had a great discussion around goal 1.
Lunch is ready.
grab lunch, and we will.
Yeah, so lunch is right out the hallway. Feel free to bring it back. Probably be relative. Brief for lunch and get back into the meeting.
Love that you live in that.
Times have changed, Julie.
All right. Hey.
He's a big wide river now.
Are they looking for power strips? Because I can't reach them. I'm going under. Oh, I can't go around.
The emergency.
I think it's gonna be a couple of years before the clinic opens. It's gonna take a while to get that. You think it's gonna go down or up?
I think
Yeah, that's a
there's
question.
been a lot of
Just discussion, yeah. There's been a lot of discussion, the current dean as to, not the current dean, James Coble, who's doing it, putting it together, you know, they have to have, they need a certain number of students in order for the school to be, for full course, because it's very expensive. I mean, they have $40 million. The new building, I think that, they saying like it's $1 million or $80 million, $40 million, something later. No, they're talking 80, but
They started with 40.
yeah, you know,
They're going up
it's
then.
supposed
I
to
know
be
they
for,
are.
it's supposed to really be for, not just Missouri, I mean, Oklahoma, Arkansas, Kansas.
Yeah.
The rendering of the itself is floors are fine. There's such a need, supposedly fall of 22.
Yeah.
2022.
Any of the dentists,
Do what? Do what?
any of our state dentists been affected by the flood?
We actually have not heard of anyone, that has said, and when the tornado came, and we called all the, that we could target, the ADA has a really cool, like, they can geo-target the whole area, but we had already figured it out by the time we got to work. And I got a hold of two of the offices, the ones in Eldon never answered, but they weren't affected. But they were just out of Howard.
They weren't like wiped out or anything.
Yeah, but Dr. Jones and Mike Jones, right downtown. I drove by his office the other day, he was like the two doors down from him was wiped out. His was. Good attitude. So, and, one of the community health centers, they were open the night. One of the, yeah. They were dealing with. It's really busy trying to tell everybody we're, like, just. It was all.
Look better.
It was good.
Oh, I know. Water.
They had that problem all the time, It's just. It's really effective. Yeah.
The water gets.
Yeah. Went over, where that hotel, I think it's still called DeVille, maybe it's called something. Highway from Capitol Plaza.
Like Baymont or whatever.
We went, anyway, I had a thing at Eris's Bistro, so you had to go back behind to get to it, and we got to it, but I was like, oh my God. A lot of water. That whole area is there.
Yeah, there used to be several people.
Yeah, but they were open Monday, thank goodness, that's where everybody went. But, yeah, it is really. And you're we're in Raymond.
So many.
It goes back to that statement.
ICD-10 code? What is that? So like,
So you use those as well as your dental, is that what you're saying?
In our software system, it's all built in. So when you click on, if you click on period maintenance, periodontal disease unspecified.
oh, so then it would be coded, let's say they also found out that person had diabetes, it would be like double coded. Identify them, get it. I was just trying to understand.
So, Karen, are you doing all right with it? Health wise?
I don't know if you heard right.
I did hear.
So that's.
Keep that. I owe you.
You got me in all.
So like, so this is their copy, right? And here's the ICD-10 code that's already automatically. And then the general code.
That's 6 weeks. That code, what is that code though? That's something from their medical, the medical people already put that in.
They do assessment time. So like encounter for dental exam cleaning, which is the ICD-10 code. And then
All right, I just had
heard about him?
but they did not think it was worth putting in.
That's what we go back.
So
I think.
continue with
We
the,
had a little bit.
Are you still on blood thinners? What are you on?
hopefully,
Oh, okay. I was on Pradaxa.
If I get another one. For you.
I don't. Mama. Here, this is why I know somebody's looking out for me.
Yeah.
When we had the meeting, fine, that following, that was Thursday, Friday. Fortunately. Did that at government.
Came into that. Like you can bring that up, you know, you can go back. I didn't go up, yeah, oh, that's right. I see his office. The other one. Yeah, no, okay. Oh, that's true. That's what's in the nature. I was just saying.
What is it?
Yeah. Wait, somebody comes out. Yeah, well, yeah. School with 80 students. I don't know if that, that's a football.
That seems to be different. Right. Different pot.
Yeah, they probably.
I currently work in Gary. Okay. I'm here. A decade ago, right? Because in general, most of the reports of 2000. Gave up somebody coming over and I don't have not all of them. I use that's right. Not a lot. And I realized that we have the day after years ago, every person had like yeah. So unless they well, most of the work has to be done by the pushing them to go. Right. Once they put that behind me. And then give it to space. Yeah. That's there. Yeah. Yeah. I don't know. I kind of go to the IT. That's right. Different, but I think. Yeah. I mean. Pretty good. He was good. Every other week, with the one day. Days on the. Now, every other week. So many other drugs that they use to offset the effects of the chemotherapy. I doubt it. Yeah, that.
Really good. Question actually. I was ready for.
In the Senate, those things.
Which.
little bit of therapy for the little guy, but mostly hers.
Don't remember it, I've seen it on commercials.
So I want you to go ahead and kind of enjoy the rest. Start to reconvene. And,
That's funny.
That's how you, well, either by name, Bruce.
That's pretty well.
Thank you for lunch.
Oh, you're welcome. It was decent. They did good. Oh, yeah, you'll never move.
I say, that's cultural practice.
What happened to all this? Hey, I knew that was. That's right.
I had nothing to do with it.
Nothing. I know nothing. I really don't. I had the flu that this last time.
You will.
Yeah.
And then you
because
left.
I was so sick. We were getting in.
Oh, that's right.
I was like, I did. I know that week. No, I didn't.
You're gonna act.
Well, I really did. I just. I know. No, when you put it over there, it looked like omelet. And it's not me. I looked it down and going, oh, that's a lot more than I thought it was.
Enjoy the rest of it as we're starting to talk. But let's go ahead and look into goal number 2. We had some great discussion around goal 1, so the exact types of things we're trying to draw out of this conversation. So really, any inputs that you provide, again, are being start looking at how does this fit back together, a plan that's going to get us into the next 5 years. So with that, I went ahead and put goal 2 up on the screen, and that was to coordinate and participate in policy development aimed at improving oral health in Missouri. Anybody want to kick us off with initial thoughts that they had when pondering goal 2?
And, the very last one, talking about encouraging LPHA to participate in community partnerships related to oral health and include oral health experts on both commissions and advisory boards. I agree with all that. So that's good, but I think that, again, I'm not sure where this belongs at. Now that we have this office, that they are, of course, the local health agencies, who, especially those where community water fluoridation. I don't think that was around back in 2000. The office was.
I don't think there was much. I don't know exactly. Yeah, there was.
So somewhere in here, there's outreach so that they help you.
So
At conferences and that kind of.
right, we go to regional training.
Okay.
Did that, you know,
Okay.
fall.
LCHA call and to encourage the LCHA not to undergird. I would love to be able to collaborate more.
So you can work with statewide public health associations.
Yes.
So increasing the availability perhaps of the Office of Rural Health to the LCHA?
I think awareness.
Awareness, really, yeah.
Thank you. Thoughts do we have here in terms of coordination and participation in policy development?
Something that has emerged in the last 5 years, well, is the Missouri Health Workforce Coalition, Healthcare Workforce Coalition. And I think that's an organization that at this point, it has no representation really from oral health. And that was, we'll have to say, by design to begin with. But I think it's time that change. And I think that collaboration and working actively with that coalition is important, because it needs to both expand its scope toward oral health, but I think participation in that. There are a number of things that are being talked about in that coalition that are important, including supporting things like tax incentives for preceptors for education and training in clinical settings, and that could apply to oral health as well as medicine. I think that is an important step taken.
Activity 2, the second bullet, and it talks about participating in development of Missouri health and policies related to oral health services. And I'm assuming that's where Dr. Dane comes in. He would be our link to that. I don't know if that meant just him, or does that anyone else that wanted to be involved? Just curious about that bullet.
So I actually was going to commit to that piece as well, with the man. I know Dr. Dane and I have been in conversations over at the law. But we've been having conversations, I think, through, providing some burden with, writers, and more members, looking at as well as maybe some standardization, prior authorization, looking across the fee-for-service, Medicaid, and care, because each differently, and that's okay, because market, that's what we have next year. But at the same time, we need to be analyzing policy with perspective, saying, okay, where are the areas that maybe they are requiring some type of prior authorization? That because really they're wasting their time and their everyone's time. Maybe we need a requirement in there. But then looking at areas that don't have where we see that there might be a need, having those conversations. And even myself, with getting up. I know there's areas or groups. I'm not sure where to get with Dr. Dane and placement or find out how we can. There does need to be that many.
But my kids standing ovation.
Well, I would like to take it out.
One of the things, dental advisory. Wasn't that big a deal to do, but hadn't done before.
Thank you for having me.
And because, the last year, get with and population is they do very risk assessment. They're paid incentives based on improvement of the population. It's a way of looking at things. It's a model that's worked there, but it took a long time for that to get. They go back to diagnosis codes. As we have right now. That requires something to at the stage where they feel like they could access Medicaid, rather than all Medicaid various risk assessment. Educators should go out to all those providers.
I think that the Carrie Health Center rolled that out. There's some things whenever you start requiring those that private practitioners on Medicaid, take Medicaid, software doesn't have this function. Okay. And linking and diagnosis. So I think there's some limitations that maybe hinder the private practice. I think it's also with Medicaid, one thing that one thing we always have problems with special assessment, kind of special. Being able to plan on a way to encourage a couple specialists, maybe allow for those growth. That. I know some CEOs are negotiating surgeons. I see, but I just talked to a surgeon having coffee the other day. You don't know that. You don't know that. I never did that surgeon too. They're not awful.
The other thing, just to piggyback on what you were talking about, Dr. King, is with our Medicaid transformation, value-based contracting, value-based, a very high priority on all of them. So we are working with actuaries to give us the most experience across the nation. That I would see being right for having the Secretary of Sheriff funding that they receive for like patient navigators, that kind of thing, to go out and find the individuals. So, even just reaching out to those individuals, kind of see if they have those oral places, that's going to happen. That's what I will see. And having them with you.
They didn't have linkages. Coming out there is pretty literature. I'm saying that heart disease, diabetes, Alzheimer's, and strokes are caused by that patients who have more of these problems tend to have more. That is to show up. Talks about value-based things. And we recognize our worthwhile conversations.
One thing you mentioned about patient navigation, which I find very frustrating. The navigators and the community health workers don't navigate toward oral health or work toward oral health in terms of education, which is a huge gap. Maybe you could talk to the primary care. Good, because I've tried it myself and I work there.
Yeah. We don't have the funding, but as part of the memorandum of understanding, have to do what's called a direct. In that, be able to direct those funds to the FCO to then have them pay to a certain. So part of that is the requirements, so that's. Never know all the things.
In terms of the activity one, provide leadership to address all. I think, and I recognize that we're the show me state and we're gorgeously unique, but I think there are best practices, our policy states that could inform what we do. And I think perhaps a more active role, at least a charge in the plan for the office to do more sharing and of other possible models, of other policies that are working in other states, that could be issue of state territories, down directions, or whatever, in a more public forum might be helpful to start driving policy.
It's sounding as if this goal is extremely pertinent still to the work moving forward in the next 5 years, but it might be time to look at some of these action steps and try to narrow the focus a bit more so that we're getting a little bit closer towards some of those practices being a leading model.
Under activity 2, the third bullet point, where it says participate in planning and policy development sessions upon the request of other cities. Would it be possible for them to actually, I don't want to say this, instead of participating, or create a yearly look at policy, look at potential opportunities to introduce new policy, or review the statistical data that the office is releasing, disseminate it, and then have work task force groups like this come together and kind of look at verbiage and possible policy that could be posed either by the NBA or coalition or NBHA. So just to do something with the data, that's what.
The NBA's been real good about developing ad hoc committees. Some industry, for instance, this work replace that at Nathan. The ad hoc committee. And policy recommend. A little more than that. Taking expertise of it, but that probably that change in statute probably would not happen without NBA. Yeah, obviously, opportunity. Issues.
And this is from that policy. That the resource stakeholder input and as much input and plan that is it won't take another 6 months to a year for then go do all these additional steps. So in other words, what I'm saying, if there's funding sources, know what kind of know what outcomes you might want to see, that kind of thing. Like if you guys are and from start to almost
code that really takes a big lift off of the table and will make it much easier to effectuate. So it's just something to think about if you, and being really focused on picking one or two things instead of having a whole thing that may go pick from this, because there are just amounts. And then, we want to see good things happen, so quick wins. And you guys are the experts.
It would just be great to have that opportunity to have like a designated time where not just the dental association and dental hygienists, not just the physicians, like to kind of really pick those top things as a unified dental community that we could kind of brainstorm, work through it, come up with something.
That intersects with that would be interesting.
Get things moving forward in this state, because it seems like we come up with these great ideas and they don't go anywhere. And how can we overcome that stop gate of, we got the idea, do with it, or how to make it happen? Everybody has to be on board for the governor to say yes. Learn that. So,
and I guess an idea enough that having extra company as well, how invaluable that. They also have a voice, capital, and they can support something guys all.
Also keep in mind that the context of the plan that we're working on is for the State Department and not as broad as we're talking, but those are definitely that we will incorporate into recommendations and suggestions at the end of this report of how can we look towards one of these task force types of activities that we can get NCOs, the Office of Oral Health, all of these partners. What are these topics?
Well, and I will just suggest that we're going to be having, as a part of the Medicaid transfer. So it may not be that you guys have to do this all on your own, but maybe we guys send it to this group to those stakeholders be able to then link that input.
I just had a question. When you're, this talks about that on the that the oral health program would be involved at the request of other agencies and other policymakers. So you wouldn't really go out do policy stuff on your own. You would have someone else request first. Is that accurate? The way it's written this way?
As written, that's how it's done.
But since you said that you're not really allowed to do certain, or depends upon the policy.
Well, if we come up with a need, idea, we may not be the actual agent. Does the person and develop a policy? Doesn't mean we can't get the data, post plan and say, go to the, Bob Joe and say, Bob Joe, look at this. Be in a discussion.
Emergency room data.
Like emergency room
Okay,
data,
got it, I got it. Okay, I just wanted to make sure that that wasn't a prohibitive thing, but it was just something that, the way it's worded, I thought.
Yeah, our office. Do a whole lot. Very little authority to do anything in the state government situation, Department of Health, very little authority. Home health that is very difficult. Relations like this to do anything over there. My biggest role, our biggest role is to educate this party that we know that are doing things. I mean, one of the best things I would like to come up with something to help access care or rural community. Don't have a working plan for that.
Thank you for that question to get us a little bit more clarity on.
Thank you.
I was noticing on activity 1 to 4, World Health initiatives such as the DentaQuest Foundation Well, that West Foundation is changing its focus on things. Partnership. What it was before, so.
Yeah, technically, the Zenicrest Foundation, Zenicrest Partnership for Oral Health.
They don't function like a traditional foundation. Big New Orleans Foundation.
So that bottom, that other wording should be changed then, so support coordinated oral health initiatives from, like that, rather than I wouldn't be specific to the agency.
Probably, yeah.
Oh, it's difficult after having one.
Well, I'm good with put out much is limited as to concrete. That's the way I think, we were doing a lot of those public outreach. Opportunity. That's down activity.
Is there a, heat map or anything that's where all of the headers are?
We are updating it. But as we speak, wanted to wait until those have their provider set. So now that they have, and we're also under dedicated providers, might be forward.
So is your plan to then take that and be able to maybe target some of the additional?
Okay. Yeah,
And maybe where we need to
that would be things that I had going on. We incentivize some of the rural.
Yeah.
That is certain. There, they gotta be paying. They got some. Make it practical. And those are the few. 5 years and
Actual, like, most of the dentists, a lot of their loans are higher percentages. Even if you just make your loan flat. But pay them off.
So the, or not. It's just. Match program. Match for that. That Berkeley provided that match money. Last year, Dr. Bain was successful in working with Delta Dental to secure additional funding for them through one of their grant programs. So the awards themselves are $50,000 per award. They are eligible for receiving consecutive awards. So where the match comes in, where that federal money is $25,000, Delta Dental matches that with $25,000.
I'm really, I have, no. theory, but practice. But it's really getting it. Did everything possible, I don't know, maybe. But if you live in a community that's rural, somebody will consolidate your home at a lower rate. Loans longer than 2 years or 3 years. General association, or your vendor who will consolidate your loan. But like, they do that. Money on it.
That's one point.
Mm-hmm. It was. I did not,
Oh. Right, yes.
Certainly, there are obligations. And Joan knows that our office. I think it's look at my. The funding that we have currently is pretty strict or very specific guidelines to how that's utilized. So I wouldn't say that it couldn't be used. One thing we mentioned community, something that has come up at several national levels, leading conversations that talk about community serving needs that we get a grassroots effort for the community that can live for either a primary care center to help do that. And are there opportunities for models to develop something like that? So consolidation, is that something that the local bank would be interested in? Bank or regional branch is there besides the hospital, I will say that with the existing program, over half of the awards that are presented.
I think that this cuts across a couple of goals. It cuts into goal 8, which talks about incentive programs. In the broad context, this is an issue I think that's being talked about on the medical side, it's being talked about on the oral health side. I really do think we need to look at, from a policy perspective, are the incentive programs having getting to where we want to get to? Would there be better ways to get to that? And try to work with Department of Health, with the legislature, with whoever, on what are the most effective incentive programs for what we know now. I don't know what the answer to that is, but I think that needs to be a fairly strong piece in this plan, is to really address that issue of what do we have now, what would work better, how do we get there, if in fact there is something that might work better. I think that's a generic thing, but I think that's worth a lot of effort if we're going to have a good outcome in the end. And, you know, the programs, I'm old enough I can remember when the Primo programs, I can remember when other programs like this were started. They're the same as they were 20 years ago, and the world is very different. So maybe we need to look differently at how we get to things. And I think that cuts across a couple of goals in the plan.
Add on to that with two comments. One, that you opened the topic of center participants in the existing. So, and then, once that person at the, so I think one thing that is aspects that might be looking at what was success at one point in time, they had changed as care, dental care. So how do we look at success for that program? Success for that, well, at least for that period, that window of time, regardless of what choice they make career, then yes, you may lose them, but that need is met for that period. Or is success that that individual is expected to stay in that area indefinitely. Well, I think, you know, we can agree that the world has changed. That's not true really in any profession. There's just a lot more fluidity with careers than what existed previously. So I think that's a topic that is worthy of further discussion.
And if your workforce pipeline works effectively, when that person leaves after 5 years, there's someone to replace them for the next 5. And that's not the traditional concept of you go somewhere and stay for 30 years. Maybe that doesn't work anymore. But you still need you need that pipeline to build so that when that person moves on to whatever they want to do in their next stage of life, there's somebody to come in and take their place.
I see where those work well is region outside of the metropolitan area. Those turnovers are easy, over every 5 years. Program never.
Earlier, in discussion of and where to speak. That was one of the primary topics that was discussed there, was the collection of workforce data. It I think it's understood now with advocacy and the allocation of resources that we have to have that data when we go and ask for those resources. And unfortunately, that's not just an area that is a gap and an area we need in Missouri, but it's one that exists in many other states. There are a few, the reference to the Shepp Center in North Carolina, the Bowen Center now. Taking great strides to be able to identify where the needs are in those states. The Workforce Coalition is attempting to be able to gather that information from Missouri, but I think that we still have a lot of work to do there, and being able to capture that data allows answer the questions that we're getting at is, how do we know that penetration has been made in certain areas, and then to be able to look at, well, why did it work in area one, but it didn't work in area? But until we have that data to kind of lead the conversation, we're kind of at a loss. It's kind of well, I had a feeling that this is what happened. They do agree that they're given me.
So this discussion is really starting to show a lot of the synergy amongst the different goals that we have in the current plan. And I think as we start to see a draft of the plan moving forward after these discussions today and over the next couple of months, we're going to see a lot of this conversation integrated into some of these different goals. They might start to look a little bit different, but the bones are all still here, is what I'm feeling we're saying. Any final thoughts around the policy on goal 2 before we move to goal 3? Go ahead and slide into goal 3. So goal 3 is about being a resource that provides up-to-date evidence-based information for both medical and dental. So something that we've touched on throughout the morning was that evidence-based that we've discussed, as well as that medical and dental. So some of the activities given there, are there any initial thoughts
anything that's working well, anything that needs? Okay.
I'm going to, I hate to go to activity 2 first, but I'm going to. The last one, provide oral health professionals with up-to-date information on infection prevention. I feel that there's a gap there. I do a lot of training and infection control training, and it's not very good in many areas. And, for instance, every office is supposed to have an exposure control plan, and they're supposed to have a plan for hazard communication and things like that. I did something with Dennis the other day. Not one person had one. These things have been in effect since like the 1990s, maybe earlier for all I know, but 86. Yeah, I thought it was earlier. But, and that I know the public health facilities have, that's community health centers, but I was pretty shocked. Even working with hygienists, it's like, we don't have that in our office. Like, do you have OSHA training every year? We have a little bit, so I think that that's an issue because, the public expects that, and at least something, I don't know how much you can do because of the number of people you have working in your office, but either this should not be in here or there should be something done about it. But or maybe there be a way to consult or, send it to somebody else to do or something like that, but I find it a problem.
There's still a need around infection prevention.
Yeah, and even, I hate to say it, even with MOMOM, got to wear a gown. These are volunteer activities. Oh, I bring my own. But we're going around and we're going into areas gowns should be done, or we're eating food with gowns on, and it just gets me. Sorry.
Beyond OSHA, which is really directed toward the workforce, protecting the workforce. So there's not really, in the infection control and OSHA focused on protecting the worker, but the CDC guidelines for infection control settings, some training that we've been providing to our health centers, and I kind of have experience in both the private sector and the public sector, and I'm kind of amazed at the private sector and infection control guidelines that they follow. I used to train dental assistants. They would come back from their rotations and have to retrain them in infection control. So, and it's just that a lot of times infection control is not really robustly addressed in dental school. So
there's a gap.
It is.
Yeah. Deadline. Things were a lot better. Of the 10 officers I saw. Most of them all had most of them were a year for that training. I'm convinced that that's about the only way to get it. I've been in an office many years. My age. Many offices supposedly run their spore checks basis. And they also always just send them to emergency, and nobody understands that it's not the place to stand. They could sit there for 8 hours and get nothing done. Yeah, there's a problem. Here, but they schedule, so it's not getting.
What I didn't see in here, I think probably should be in there, you should probably call out the need to, I don't want to say educate, but make them more aware about prescribing of opioids. That's something that's come up since then, and I think that probably is significant here.
Especially since Dennis prescribe the majority of opioids.
Yeah, for teenagers.
I guess it's activity one. I'd suggest maybe we need to split something out here. The term medical setting causes some issues when you're talking about nurses and other things, other providers who are not physicians. I think there might be a reason to talk about the ambulatory care or primary care setting, and then separately talk about, we don't mention things in terms of the educating emergency department providers, which also gets to the opioid piece, and hospital outpatient departments, which are seeing more and more patients that otherwise might have been seen in practices. So it may need to be two kinds of activities. One that is directed toward ambulatory care, primary care, an additional one directed toward hospital issues that go along with that.
We don't have as much of a problem with emergency department visits anymore. The physicians in emergency departments really don't understand the fact that the prescription of antibiotics or an abscess tooth does not address the root cause. And once that course of antibiotics is over, the infection is going to flare again and go back. So you're needlessly prescribing antibiotics. We already have so many strains of bacteria that are already resistant, and you're not addressing the fact that the patient needs to see a dentist. So that kind of education for physicians, especially in emergency departments, I had several doctors tell me, well, antibiotics, and I'm like, that works for your toe, it doesn't work for you.
Go along with what Mike was saying, that see more and more people use clinics too. That perspective, I've seen more and more patients.
It's something that wasn't prevalent when this was written.
I'm sorry, using what kind of?
The clinics or the care.
Yeah, they don't want to see you anymore.
Think about that we learned at Computer when we were starting to talk. The doctors at the hospital, they know that it's just a workaround there. At the time, because just sending somebody that was like annually going back there, patching, still don't know it. Down the street, so park. Possible. And I've gotten a phone call from you guys, but like back when Amy was there, hey, someone called me, area to see that. But also, just having an office doesn't always solve the problem because you're booked out forever. But clinics that do well in accuracy that are able to have emergency departments. Find the best practices that the health centers that are able to do that. And City Middle School has one, and Valley has one, Country we have an emergency. There's ways to agree, you don't have to have it every day, but like just encourage that kind of thing digitally or that we're at the health centers. A lot of people want to do that, but a lot of people say. Question for Bob. Do we track services that are provided in these care plans?
There's claims, but.
Well, I mean, it'd be claims based on the API numbers, but I mean, that's one thing you have some data from service. But as a group,
Maybe they have a different provider identifier. We have to ask, like, Dale Clark and.
where we're talking about minute clinics, maybe the reason we're seeing
And that could be a challenge because you can't separate out that data. If that is, we're not. We do see that, like the Jordan Valley, we do prevalent ER visits where they do availability.
Yeah, statewide, that's a drop 44%. LED. But there are pockets that haven't changed.
And that's the piece I don't know is the difference in police visits versus.
There educational parts of it. One of the things that out to me, number of physicians and communication, number of physicians that don't want to be involved and that experience that we approach all providers and get a couple of documents. We have signed up. Now, you never know. Get into the political realm and get their feet in the river. Education, it makes a difference. I understand why. So, yeah, we know that we need more education in that area. And the American Cancer does a good job of providing information. Not sure that they read it.
I was gonna say something about that because education is very important, and I think, like you said, we have really tried to get our members aware, and I don't think there's any pediatrician who would say they don't know anything about fluoride varnish, how to apply it, when to apply it, because this has been going on for over a decade since the Surgeon General's report. But there are still people who don't do it despite all the education, and it's important to find out what the root cause is. And so it might be helpful to see, is it reimbursement, the time, and then see if we can overcome those barriers, because there's definitely barriers to it. It's a very simple procedure. Over in our local area where I practice, we've gotten it down pat, so don't even think about it. Everybody gets it, but it's not uniform at all. So looking for a way not just to educate, but to give feedback, maybe the statistics of that particular area, how many of you are doing this, and the effect might be helpful too, I think. So people can see that what they're doing is useful and has long-term effects. I envisage a world where we don't find 2 or 3 year olds having to go to the OR to get their teeth rehab. That's what we all look for, and we're really into prevention. And anything we can do to encourage, not just pediatricians, but family medicine, anybody who sees, APR, and anybody who sees children, to take this seriously will be very, very important. Right. Wait, there's 4. Yeah, they're not mentioned.
They have any ready and all that?
No, they don't. That's what my daughter wants to be, and they don't have any oral.
And there's opportunity there. A lot of great discussion on kind of how to break out some of these action steps to make them a little bit more targeted. The one that we haven't touched on though is activity 4 in regards to long-term care. What are the thoughts and feelings about that activity?
Yeah, Office of Dental Health is already doing this, but I think we should probably put it in writing that we'll encourage teledentistry activities in long-term care facilities, because we all know that the status of most residents' oral health is deplorable.
That's right.
I was just gonna go, the only thing I was thinking about when Dr. Dane was talking before about many of the dentists are not using sealants, I'm wondering if that under activity two, that should be something prioritized, particularly since we have to grant some different things on sealants that maybe, maybe push the idea that the newest information, the most updated evidence-based stuff, sealants that, I've heard so many people say, oh, you're getting decay, going to get decay under the sealant. Well, you shouldn't seal if there's, a little bit of decay there, which, all that stuff. And that's just a thought. Maybe that should be prioritized with our dental community to remind them that sealants are a good thing.
I just thought of that. We have an acting group. But I feel like that. Always agree. But the unwritten that de-emphasizes as you look at what we teach. And boards. Nothing on the boards about dentistry. Either gets de-emphasized or, don't waste your time on that wrong. Because part of what's on the, I don't know about, AT still got parents feels that they have to do everybody. Sure that in case he does.
And I disconnect between best practice and what's being done didactically.
Well, I think there's just particularly with the experienced older dentists, they really think it's there. You put a sealant on, you get decay under the sealant. I mean, they complain I'm not putting them on because they're getting decay under them. Well, maybe they're not well sealed, maybe they're whatever. A lot of issues involved, but anyway, thought that might go with what grant money and things are going.
Back to long-term care. Our folks at the bar at the table there.
No, I think it's important. The one thing that I always emphasize when I talk to the individuals, access that the rest, that's my big thing. And I think that's our.
Of us are reaching. Yeah. I mean, I don't want to. Yeah. That's like 40%. 48%. We are rapidly the paradigms. So if you're taking care while you're working and you have dental insurance, Medicare.
Well, definitely not for this plan, but there is dental coverage included in Medicare. Personally, there's also, there's a lot of discussion about Medicare for all. Typically trying to anything like that done.
So should that be under our policy goals, to reference an oral health benefit Medicare system?
For the Department of Mental Health, the challenge, and then those who also or beyond just the dental services processes as well. The department is working on a database that will allow us to gather information out of this. This group is probably 2 years making still, but So within that, if we could get a better understanding of exactly what kinds of questions or what kind of data you would be interested in us collecting, we can look at building it into the database, but also any information and dissemination we can, I think, queue up in like some informational text behind about why this is what to look for. Could be an opportunity to our long-term care folks.
I think, two very brief things. One, I think this is a place, this goal is another place to infuse education about social determinants of oral health, because it fits for all of those activities. The other one that is only mentioned, I think, once in this plan, because, again, 5 years ago it wasn't as prevalent, but community health workers, I think, is a critical thing to address, because we're now moving very close to certification of community health workers in Missouri. There's more standardization happening, but oral health may or may not be part of that. And I think there's an important thing to call out the role that community health workers, talking about prevention, oral hygiene, types of things, where they can have significant impact.
I use your name.
Several people joined.
The Ensure Public Health Record. I know. Up the top head. I'm wondering, are there other groups besides the LDHA that would fall under this category that should? Public health provider groups are out there talking with that talk. We do talk to school nurses, I do, webinar on them. Talk to them.
Administrators, I don't know.
Maybe,
Doing the SDHC, correct?
well, we go to all of them.
Waste officers,
Providers.
that's what where we got
Parents
from.
and teachers.
Well, that's not, this is public health practitioner.
Public health.
But our home is eligible families and those.
Do they have a meeting or something that they access?
It would probably be disseminated through our HSS, isn't it? Works with that program. So, I would say disseminated through and the list of providers who do that, children's mercy. Like a collaborative program where they are trying in the areas of their tracking outcomes and making sure.
I know that, yeah. Leslie McGraw, I know that we're working with develop, instructional, field that will go out. Thinking of business.
Like, we were just talking about like the Head Start program, the MOCA, that all Head Start colleges.
They, Head Start does a good job in terms of, I'm not real, but,
about the home health and.
That's what they're talking about.
Yeah. But, SHCN, they still pay for a pallet repair, so there is some awareness of whether or not that's carrying over into,
Those emergency room doctors you were talking about, that, I don't know if we do them already.
I feel like there's large components of what the Department of Mental Health does that's really, they don't think of themselves as big. They often touch.
Theirs.
Do all of the schools? Yeah.
What about like, assisted living, like, I'm trying to think of like, yeah, thank you. Yeah, like, people who have mental disability are in a home for, we have a lot of that patient pool at ours, as well as, juvenile detention centers, and, like Piney Ridge is where, like, it's a rehab, and it's a behavioral rehab facility, and they're required to bring their children to us for anything on the fund, and then if they're in a good behavior, so that's keeping them trained. So, and it's kind of trying to make that easy. Great to get with.
I'm sure that they,
But
I don't know myself whether or not that access point.
We're on task force.
Lots of opportunities.
If we come back to a situation where there's tons of opportunities, that was all the discussion, we're gonna get priorities on this. That where we should put in most of our. There's long list, long run. We did, used to provide a little care team, to them, but
Those are priorities and action steps getting very long. That's a good thing right now. Yeah. So we're thinking around the resource. Around people. But on to goal number 4. Goal number 4, we're looking at increased awareness and knowledge about the importance of oral health across the life. Really that focus in on the life. Had some of these discussions already, but we broaden it out a little bit. So up here. Education and awareness.
so as far as activity 2 and 3, are you all working with the faculty? Thing with them.
they felt that it is available, yes, to the, video program. Not a lot, but, done to promote that, I know they have done some that, but again. Okay, problem with,
Say that, I know they have the, school modules, and a lot of people don't know that they're available, dental professionals, maybe even nurses, I don't know, maybe talk to them about it, but, since that is available, ought to be utilized better and letting people know that they're there. But of course, Britain, there wasn't a lot of discussion about safety. Just recently, I had nurses down here, but something like that, I think, put in here. Cancer, it's way up in the moon.
Would tobacco cessation also encompass vaping?
Yeah.
Or would that need to, I mean, a lot of people don't think about vaping as tobacco because it's a.
Probably needs to be
Yeah.
Yeah, I mean, every time they do another little research project on
It may be worth connecting their, going through a process with the tobacco system, updating the videos that they collecting that as a group, it would be connected with that. And we are actually going to turn it in session and share.
I don't know. You guys give me training in that station?
Yeah, no, it is required, tobacco and, so they have to do a screening. Tobacco and. Yeah. Regular. First dose.
Would it also be warranted in that same bullet point, in regards to the tobacco cessation, include chronic disease in general? Because it's smoking doesn't just affect periodontal disease and oral cancer. It also has a huge role in other chronic diseases. And if we're trying to bridge that with systemic link, it might be nice to line that. Lifespan is a very big spectrum. Is there anything that we have touched on for portion of the life? Also under activity, provide education to the public and community during the it might be prudent to also about our legislators. Something like that, because they're the ones who are unaware completely of what they're the ones who are really drive our efforts, have a bigger impact in the big picture.
That's true, at the local and.
Yeah,
Both,
not local
not just
government.
the government.
Yeah, exactly. Everything. Thank you.
Thing that comes to light whenever patient challenge, you always ask for ministers. There. Or another council. Yeah, usually there's somebody, but not a great deal that maintain that relationship. neighborhood values. It's more about stories than those. Those next door to me. Talking to him about it.
I think the University of Missouri, the IHD program, they have they received a Living Health grant, and we're just a couple months or if it's going to get into opportunity, both some education around that, but they're using their life course tool, which does promote education with the life course that they have out there. So there might be some opportunities there that reach out, or I can connect you with who might touch base with if there's that grant or just efforts with help.
Okay, sorry. Under activity 1, it talks really broad, and I think broad is good, about the keys to good oral health, about educating them about oral health, but it doesn't specify how to brush or how to floss. It would be nice to have that, not just talk about you should, but here's how to. That's a lot of why they don't, because they don't know how to, don't do it. We focus on talking about you should, here's why, but we don't talk about this is how.
A little more concrete on the actual. One piece that I don't see in here, and I know it's more prevalent as our population does age, is caregivers. And I know you're working with Lily to grow students and caregivers, things, so I really want to see some of the education. Because we know that there is, and how they can help it, with oral health. So I'd like to see some.
And that might even go back to goal number 3, to adding care providers as a.
Question. I wonder where outside of an urgent care or emergency room, somebody who hasn't established care with a dentist can receive urgent services? Because practically speaking, what I see is that somebody has a toothache at night, they'll go to the urgent care. There's really no urgent dental, of services available. So the problem that we often find is follow-up after they've already seen the urgent care person and gotten the antibiotics or painkillers or whatever the next day. I see a lot of patients who come to me who have been seen in the emergency room maybe in a week or 2 before, who never went to follow up with a dentist after they've been seen because they feel better. The pain went away, they're fine. And I have to impress on them the reason they need to go because they have a problem. So I don't know how to make that better because under activity 1, it says encourage Missourians to seek care for urgent and non-traumatic dental problems. Could there be a list of such providers or a number they can call or something they can do? Because you automatically just go to the urgent care. I have a toothache, it's hurting, my head is hurting, 7 o'clock, I'm going to be in the urgent care. I don't know how we can encourage that if there's no other place for them to go.
We look at, they're eligible for Medicaid action. We know across the board that only about 45% general population annual dental visit last year. About the same amount, but we'll tell you that they can identify that all. The other question about feel like you have good oral health and 5%. Then you look at
Great.
so I think it's still that if you're not hurting, you can't do oral health. Yeah, that's part of the problem. And it's across the board. Literature out there. Something. Maybe. Markers.
We'll tell you that the DHSS website, we do have a list of dental providers that are sliding scale and FQHCs that are listed for work by county.
Okay.
Some counties have several options, have none.
Okay.
But you can always look in there and just what's available there. And we update that every Tuesday. As you realize, clinics come and go. This summer will be the summer we update that. So new information will probably be added to that October or so, but right now it's up there by Tuesday.
It's something the public might have in the publication, you know, like a number or website to access. Because when they're having that problem, they're just not thinking, want to go to here. Yeah. But if that was out there, maybe, you know, like all the poison control when you have a problem, you know, everybody knows that number, I think we all know that, so.
My thought was, and it's great if we went by emergency rooms and even urgent care centers and provided them those phone numbers and those clinics specific to that county or area, that would be ideal.
Yes.
Did a pilot project,
Okay.
is we set up a referral system 24 hours, next 24 hours, from the dental school or 3 to receive care. So that appointment was made at their discharge. At best, we had about a 30%. So usually around 15 to 25. And then and I know some other communities picked up on that and have gotten funding where patients are given vouchers to use anywhere, the 8-hour period, and they still have a very low utilization rate. So I like the idea, but we just.
Are they leaving the ED?
Do that.
They're leaving the ED.
Usually just one pain pill.
Well, what's like a GHB while I'm feeling better?
And that's what we ended up, is that most of them were, but they're.
But what we learned in our pilot, we looked at that, was, the vouchers, it didn't work. But as soon as the emergency room had a place that would take them, then they were confident they didn't have to do biotics. The problem, I know when I was a child, it was super dentist. Problems. But that's the way it is. And changing that whole focus cases cultural thing. They have the low dental IQ, if you will. We're not meeting that's a lot of places around. There are recipients of Medicaid that don't realize it. Or they may say they don't. I know that every managed care plan, my brochure, page about dental services that are available. So.
It would be really cool too to have, like, you know how doctors are on call, have dentists on call for ERs, like that the ER staff could call the dentist and say, hey, we have a toothache here. Can you help us triage what we need to do with them? I have several
Having
people.
worked in the hospital, thing with that hospital.
Right.
I've had this toothache for.
Oh, yeah. Now it's an
Oh,
emergency.
yeah, today, now just give me, I'll get through the night,
Right.
what's your name, John Smith?
Right.
It might as well.
Yeah.
Are you saying or say that members that have dental insurance are about the same as them following up with dental visits as well?
So it, also, we used to say that, fear was the biggest reason. Yes, you know, economics can play a role in healthcare policy. But, well,
You've got your and dental visits, but your eye exam, you know, when you're talking
for an extra thing. Yeah, worry about that later. Very cultural.
You know, and transportation does play a role. Talk about if you have transportation, major part of the city, transportation district, you have problems getting work, grocery stores, medical visits, as well as dental. Medicaid transportation will take you, you've got kids in the middle. Right there. Years.
I think the shopping going from Medicaid patients, private patients, don't get them. Private insurance is not covered. Extra expense. Well, either entirely or just not paying copay. Then those wait, so they have to have capital, they'll get back. But, that kind of plan is designed, is when you go to a school, there's 100 kids, 60 of them have Medicaid. You'll have to deal with them. They often just let them have cavities. Awareness about dental facility or private life would help our state members get better insurance. But I don't know how our plans compare to others.
That is messed up.
What insurance? A lot?
For all of it.
Is it because the employer package doesn't allow them to, or is it because, okay, so there's
That would
a,
be nice,
yeah. So I think it's, I don't think it's really covered, because I know that some of them do. It's because the employer group has decided not to cover that.
Also, Delta's starting the value-based payment on you. And that, how that holds us back up. But I laugh because it's like, sometimes it's not.
You're.
Yeah. And also, I know that also starting you, our PSP program is a field program. Decided to stop doing fields on billing private patients because they have copay to pay, find that off. Things like that where you can make it easy. Operate.
I'm gonna start to wind down this great conversation that we've been having around Goal 4. This is Goal Clear. We will pick up on July the 12th whenever we reconvene for our next meeting. So what the next steps are looking like, we're going to continue discussion around Goal 4 if there's any follow-up for that next meeting, and move on through Goals 5 through 9 and wrap those up. Between July and the August meeting, we will start developing a draft plan of the new proposed oral health plan that will then start prioritizing the system, start narrowing down what the true focus is going to be for the next 5-year plan.
Other than this, thank you for your discussion. And, it's good for everybody to, and your schedules are difficult to break away. Have, phone calling numbers. To help facilitate conversation. Please, we got some questions about the page.
Nobody objects. Could we get a list of the work group participants and their, organizations that they're affiliated with and their email addresses?
We get that.
Well, you don't. Okay, and that way, I'm not on the people.
I also want to, a couple little, nuts and bolts things, tidy up after. Leave your name tag on tables outside the door. And this is an important group, so I'd like us all to get on the steps up. Anybody else would like?
There you go. Actually, like something to say, but I'm kind to make a reservation. I mean, I think you're right here. Okay, so you put your number. You too.